Good afternoon and welcome to Washington State Public Health Association's February webinar, Aligning Public Health's Workforce with Public Health's Future. Before our presentation begins, I just wanted to go over a couple of issues with you. First of all, you do have a control panel on your screen, and if you have issues with your audio, you can switch between the telephone and the microphone on your computer. Just click on the buttons and follow the directions. The presentation slides and recording will be available after the webinar. If you would like to get them today, you can send me an email. Otherwise, they will be posted on our website. And if you have any questions, we will be taking questions through the question box, also in your control panel. Please type them in, and I will be posing them to our presenter at the end of the session. I'm pleased to introduce today's presenter, Dr. David Fleming. Dr. Fleming is the Director and Health Officer of Public Health Seattle-King County. Previously, he directed the Global Health and Strategies program at the Bill and Melinda Gates Foundation, where he oversaw portfolios in vaccine-preventable disease, nutrition, newborn and child health, leadership, emergency relief, and cross-cutting strategies to improve access to health tools in developing countries. Additionally, he has served as the Deputy Director for the Centers of Disease Control and the State Epidemiologist for Oregon. He received his medical degree from the State University of New York Upstate Medical Center and is board certified in internal medicine and preventive medicine. He also serves on the faculty in the public health departments of the University of Washington and Oregon Health Sciences University. Thank you for joining us today, Dr. Fleming.
Good afternoon. It's a real pleasure to be here. Thanks for that very gracious introduction. I'm wanted to talk with you today. Reprise a bit of a talk that I gave at the Centers for Disease Control in December of this year at a national workforce summit that they held. And I thought it would be important to start off by just giving you a little bit of a context for how I wound up giving this talk, because as you've heard from that very gracious introduction, there was not a whole lot in there about workforce training and workforce expertise that would make me an expert. I used to work at CDC, and when they were thinking about convening this national summit on the public health workforce, they asked if I would be a bit of an advisor, and I agreed. And then, maybe a month or so before the conference, they called and asked if I would give a talk at the conference. And the tone of that ask to me was, we want you to come and talk with us about workforce development. I told a nice person that was calling that I really did not know all that much about workforce factors like training pipelines or faculty development or innovative educational strategies. And word for word, their response back was, oh, David, that's perfect, because there'll be tons of people in your audience who know all about those things. And so I realized that I was in a little bit of a problem, because I was going to be speaking to a group of experts on workforce development and needed to come up with something new to say to them. In that context, I got a little bit of the inspiration for what I'm going to be talking about with you today from the national presidential debates, of all things, that occurred shortly before I was asked to do this. Now, since public health is nonpartisan, let me first acknowledge that both of the candidates in the presidential debates made many excellent points. Unfortunately, most of them were not about the public health workforce, but in the debate on October 22nd, there was a very spirited exchange that started with Governor Romney criticizing President Obama for there being fewer ships in the U.S. Navy today than in 1960. And for those of you that were watching, wouldn't you know that this would happen? I've lost control here of my slides. It was working perfectly before. I wanted, Jennifer, can you help me at all here? Or am I stuck? Jennifer, can you help me, or the moderator at the Public Health?
Oh, I'm sorry. I can pull up the slides and advance them on this end if you would like.
Yeah, why don't you do that? I apologize for this. We knew this was going to happen. It was working perfectly all about 30 seconds before we were going to do it.
Okay.
So I would just...
It will be up in just a moment.
I will just tell you as we go along to advance.
Okay. There we are.
Okay. And so, as I was saying, in the presidential debate, when Governor Romney made the point about the U.S. Navy today having fewer ships today than in 1916, the president responded saying, well, Governor, we also have fewer horses and bayonets. And basically the point he was making is that times are changing and the military workforce needs to change with them. Well, the same thing is going on in the world of public health, and I'm a little bit concerned about whether or not we're identifying the people and the skills we need to be successful in the new world that public health is going to be facing. And so I want to focus this talk today to talk to you about that as an issue. I think there's probably no one who's listening who would think that the world in which public health is practicing today is not undergoing important changes. If there is anybody, maybe we could, I could talk with you afterwards, because I think almost everyone would recognize that we're living in a time of perhaps recovering, but deep economic recession. We're living in a time when there's increasing distrust of government. And we're living in a time when healthcare reform is on the verge of happening, and there will be profound changes in the relationship between public health and clinical medicine. Now, the reality is that many of these changes that we're facing are external changes, and so we have little control over them. And therefore, in the context of adapting, we need to think about the internal challenges that we're facing and how we need to change internally. Next slide. It's, in my mind, and this is what I talked a little bit about with the folks at CDC, public health in the 21st century, from a problem and program standpoint, is a bit schizophrenic. On the left-hand side of this slide is a graph that shows life expectancy in King County, where I work, back over the last century, from 1900 to 2010. And there has been, as we all know, this remarkable increase in life expectancy, about 75% of it, according to best estimates, solely attributable to the work of public health during this time as opposed to clinical medicine. And so we are currently living in a century where much of people's increased lifespan is directly as a result of the things that we historically have done to reduce infectious disease and maternal and child health mortality, but things that we are currently doing in those arenas as well. Now, on the right-hand side of this is a close-up of life expectancy in King County over the past 20 years or so. And the blue bars, top of the blue bars, represent what has been going on with healthy life years. The red bars stacked on top of that show the average number of unhealthy years that people live before death. And the sad reality here is that although life expectancy has continued to increase, many of those gains in recent years have come by the result of unhealthy life as opposed to healthy life. And so as we are thinking about our effectiveness in increasing life expectancy, we also need to be recognizing that a fair amount of what we're currently producing is not quality life. Next slide. And so when I go to lectures, I always realize sort of after the lecture what the most important slide in that lecture was. And so I thought I would label that here for you, because this, if you take nothing else away from this, I think is sort of the bottom line here. And that's that in this time of unprecedented change in the environment in which public health is operating, we face two simultaneous challenges. The first is to protect those historic successes that have got us this far in improving the health of the people we serve, but also to confront the emerging challenges that have resulted in a bit of stagnation in our effectiveness over the last generation. And the premise of my talk today is that actually in public health, I think we face a significant chance at failing at both of these unless we take steps. And in particular, our workforce skills and our workforce today are at a significant mismatch with the needs of public health going into the 21st century. And in addition to just getting more people interested in public health, we need to pay specific attention to the development of new expertise and new competencies, new skills in our workforce that we currently do not have. And as we do that, we need to think about those new skills and workforces in the two buckets on the bottom right. First, those things that we have historically done, we need to be thinking about, are we doing them in the right way, the most efficient way? And the second bucket on the right, as we move into the future, we also need to be thinking, do we need to be adjusting the programs and the services that we're offering in public health to confront those emerging challenges? Now, I was trained, not very well, as a speaker, and you never give more than 3 points. But in thinking about what the new workforce skills and competencies are, I failed at that. And so I'm going to talk about 4 things relative to doing things right, and 4 relative to doing the right things, 4 new workforce competencies. In addition, I'm going to throw 1 in at the end to talk about 9 things for the rest of my talk. 9 is divisible by 3, and so I think I'm still sort of in that talking only about 3 things pathway. Next slide. Even breaking that rule of 3, I think I found I needed to be pretty stingy in talking about new workforce competencies. So my list is not all inclusive. It's going to be designed mainly to hopefully provoke your thinking, more of a sampler, if you will. And so I've specifically stayed away from new workforce skills that I think all of us would recognize that we need to put into place. And as a consequence, this is the first and last slide that you'll see that mentions IT, or information technology. Clearly, there are major changes in our workforce relative to this, but there have been lots of talk about those, so I am not going to talk about them. What I am going to do is now to march through 8 different needs that I see that public health in the 21st century will need to confront, and then what is the new workforce competency that we specifically need to develop in order to confront that need. So number 1, let's go to the next slide, please. This is in the category of doing things right. Because we're all challenged by budget pressures, although it sounds trite, the need going into the future is actually to do more with less. And that's hard to do, but I think that's the reality. Now, when I gave this talk at CDC, I, as an example, asked people in that room how many of them knew what a Kanban was, K-A-N-B-A-N, and nobody in the audience raised their hand. This is a picture of one on this slide. Basically, as just one example, in King County, and this is one of the few stories I'll tell, we have a permitting program for restaurants and for permits for housing and for commercial development. That's a very good permitting program. It has been operating for probably generations. But because of the current economic crisis, was facing a significant budget shortfall. Fortunately, somebody on that team had experience with Toyota lean manufacturing processes and introduced the idea that maybe this unit could be made more efficient if some of those practices that are accepted in the manufacturing world were accepted here. One of the key concepts in the manufacturing world is that inventory is a place that can be where you can be either efficient or inefficient, and there's been a whole methodology called a Kanban developed where you can, if you can visually see the inventory that you have, you can much more efficiently use it. So one simple step in this program, the historic practice had been that when permit applications came in to the department, they were parsed out to individual investigators who would process those applications at their desk and occasionally pass them around from desk to desk if there was specialized expertise that was needed. The simple change that was made was at the end of each day, rather than having pending applications stay on each person's desk, that everybody agreed to take them and put them centrally into this filing system that's shown here. That filing system is arranged sequentially so that applications that were the least processed are on the left, the most processed on the right, and the step that was delaying their advancement labeled underneath. So that meant that each morning when people walked in, they could see exactly what the entire workload of the unit was and could see exactly if there were roadblocks where they needed to pitch in to help out. This one change in this program increased the efficiency and throughput of this unit by 30%. Next slide. So that first need to do more with less, I think the new competency in public health that we need to be considering is the competency of having public health business experts. In particular, people who understand better continuous quality improvement approaches, who are able to use standard business process improvement tools like Lean or Six Sigma, basically business process re-engineering, have an understanding of those tools and to apply those tools and approaches to public health programs. So that's number one, and doing things right. Next slide, please. And with a little bit of tongue-in-cheek, the next need that I see out there is we need to immediately prohibit epidemiologists from designing our surveillance system. And why am I saying that? Can you advance this by one, please? Now, we in public health have done a great job in surveillance and in measuring the health outcomes that we're trying to influence in our population. We're probably as good, if not better, than any country in the world in doing that. But in the process, I think we've missed something. Advance the slide, please. There's this notion that actually, we get resources in public health to do things. There are inputs to our projects, and somehow those inputs are influencing those health outcomes. But my bottom line here is that we've not done a very good job in measuring this process. Advance the slide. And the reality is that in public health there is a value chain that starts at resources, go through the capabilities that we build in our health departments and other community-based organizations, then programs and processes, products, how we're actually translating that money into something we do, short-term outcomes, and finally long-term outcomes. We have been historically much too focused on the right-hand side of this value chain and not at all, in my mind, on the left. And unless and until we change our concept of what it is that we should be measuring, we really can't hope to use information to improve what we're doing as opposed to only measuring the outcomes. And so the new workforce competency that I would propose we need, next slide, is program-centered epidemiologists, basically epidemiologists who can identify actionable measures along the entire public health value chain, especially program products and linkages to budget inputs. And then to design and implement rapid cycle surveillance systems that measure not only outcomes, but measure these actionable measures, and then report on those key measures to program and policymakers. That was number two. Number three, next slide. The third need that I think we need to confront is that we need better research that is actually determined by practice problems. Public health research is in its infancy. We tend to think of applied research as research that once we see it, we might be able to use it to modify programs. But we need to do a much better job in actually developing a research agenda that is dictated by practice problems, to understand all of those things that we're not measuring well in that last competency that I talked about, and put in place the research to help us measure those things better. Next slide. And so the new workforce skill we need are practice-oriented researchers, basically researchers who are knowledgeable about public health programs and strategies, including the implementation barriers and challenges that we face in practice. And individuals with the research skills to conduct cost-effective studies using a variety of research designs beyond just randomized controlled trials, including in settings where data is incomplete and time is short. The real world, the dirty world, researchers who are willing to get their hands dirty. Number four, next slide, and the last of doing things right. One of my favorite movies is Cool Hand Luke, and one of my favorite lines from that is Paul Newman's, what we've got here is a failure to communicate. And I think we need to recognize better that we are at a particular disadvantage in public health, aren't we? That we've developed an internal way of talking with each other that may be at a mismatch with the rest of the world. So as an example, in public health conferences that we all attend, we are very, very careful when we're presenting to talk about an introduction, then the methods we use, the results we found, a discussion, and then the conclusion. In the rest of the world out there, advance the slide, everybody starts and finishes with their conclusion, and by the time we get to it in public health, nobody's paying attention to it anymore. In public health, even when we get to our conclusion, we are very careful to caveat it, say all the things that could be wrong about it and all the additional work that would need to be done to be more sure. In the rest of the world, advance the slide. Keep it simple is the rule, because only by keeping it simple will people remember it. In public health, when we're asked a question or when we're talking, we feel the real need to give a complete explanation of all of the variables and cofactors that could be influencing the issue that we're talking about. In the rest of the world, advance the slide. People listen and are accustomed now to speaking in sound bites. In public health, data are king. We are research-based, and if we can't prove it statistically, it's not true. When we try to talk with others, we do the same, and we all know that in the rest of the world, stories are what it is that's compelling to people, and that's what people pay attention to. And finally, when we're asked a question in public health, our tendency is to answer the question. In the rest of the world, you need to answer the question, you need to stay on message. So we are pretty hamstrung, I think, with our current ability to communicate. We have a need to do better, and so next slide. The workforce competency that we need are clear, persuasive communicators, in particular people who have the ability to translate into English in real time scientific and public health concepts that are tailored and understandable by the audience that we're speaking to. And in addition, beyond that, at a higher level, the ability to design and implement issue-specific and organization-wide strategic communication planning so that our communication folks are spending most of their time proactively thinking about what to say in the future as opposed to fighting the fire of the day. Next slide. I'm switching gears now. So those were the first four about how we can improve our current practice. We do need to recognize, though, that the world is changing around us. Look at causes of death as shown on this cartoon from 1912, where the leading causes of death were infectious disease, to 2012, where the leading causes are chronic disease. We've undergone this amazing epidemiologic transition of what people are getting sick from and what they're dying from. And as a consequence, the nature of the programs and the nature of the interventions that we need to be focusing on in the world of 2012-2013 is different. And we need new workforce skills and competencies because there are new needs. Next slide. The first need I would want to sort of raise here for you all to think about is what I call the need to look above the roots. As we think about the most effective ways to reduce the incidence of heart disease or cancer, we need to recognize that much of that is about systems, policy, environmental changes in the community. No longer are we in the business of pretending that we're going to treat each person individually, even through health education, and it's through things like clean air smoking tax, strategies to implement safe routes to school, the whole litany of policy changes that we're actually going to be making the biggest difference. But I think in some ways, given that that's our new mission, we may have among all of our deficits the biggest competency gap here. Our background, our nature, sort of the roots of public health are that even when we think about community organizing, moving from the individual to the community, even when we think about community organizing, we tend to think about grassroots, about working directly with those who are most disenfranchised. And while we need to continue to do that, we also need to recognize that actually to get policy change in the community, you need to work at the grass tops level. You need to work with the people who have the power in the community to make those changes, and you need to have the skills and the competency to do that. Next slide. And so the skills that we need in the future are what I call policy enactment experts. Individuals, and there are people out there, not in public health, but in other disciplines, who have the ability to understand, develop, and use power relations, power dynamics in the community to successfully enact policies. And second, to use adaptive leadership skills that facilitate partnership and collaboration, because our job in the future is much less going to be able to tell people what they need to do, but rather to persuade community and policymakers of the actions that they need to take on their own to become healthy. Next slide. So thinking again into the future about the new skills to confront our new challenges, this one to me was, again, a little bit tongue-in-cheek, but thinking like Margaret Mead, we all recognize that as we've been successful in improving life expectancy and as that disease patterns have changed, they've done so preferentially. And so when you look in any community now, where I work, King County would be an example, at who it is that's being affected by chronic disease, the answer is that increasingly it tends to be the poor, communities of color, people who are marginalized from society. And as the diversity in our communities increase, we need to recognize increasingly that the approaches that are going to be most effective to tackling these problems of health disparities are not approaches that a majority culture is going to intuitively go to, but instead we need to work to understand individual cultures and what you're trying to make differences and implement interventions that are going to be effective for the people who are most affected. So thinking about that from a workforce competency, again with a little bit of tongue-in-cheek, next slide. I've called this new competency anthropublic healthologist, basically the idea about incorporating more systematically into public health the skills of anthropology. And this would be individual skills to routinely use anthropological concepts and methods to identify interventions for our most vulnerable communities, but also to recognize that there's an organizational competency here as well of cultural credibility and knowledge, and that increasingly we need to be thinking about ways broadly to attract a more diverse workforce into public health, and that includes a workforce that's more ethnically and racially and linguistically diverse, but also politically as well. Next slide. Okay, so the third one of these is maybe an obvious one, but I felt it was worth raising, and that's the notion, particularly with impending healthcare reform, of the need to get public health and the healthcare system back on the same track. I think that maybe at the beginning of the last century, those two were very close together, but over the last generation, skills and competencies and activities of public health have diverged from clinical care. With the Affordability Care Act, with an increased proportion of individuals now potentially insured and not in need of indigent care, but with an increased attention by the clinical care system in prevention, there's this window of opportunity for public health and the healthcare system to once again realign. But we don't necessarily have the competency that we need to do that. And on the next slide, we've lost in many public health departments the clinical competency that makes it so that we are credible and understandable and relevant to the clinical practicing community, recognizing that the clinical community is where the money in the future is going to be for prevention. We need to be thinking about the workforce skills that we need in health departments to be able to influence the delivery of health care to individuals in the community. And we need to be able to do that by having people that are understanding of healthcare delivery, are competent and credible in it. We also need that same set of skills to leverage the participation of the financing and participation in financing of the healthcare delivery system in achieving the more traditional public health goals of community and population health. And then finally, the last one, next slide, looking forward into future. Again, tongue-in-cheek, but the need that we have in the future is to steal the ideas and the money of our economic development colleagues, particularly as we think about increasing health disparities. We need to recognize that the focus of our work is going to be in our poorest communities, and that also is the focus of folks in economic development. If we're thinking about changes in our poorest communities that represent the environment that people are living in those communities, having healthy stores, having streets that are safe to walk on. Basically, those very much become the same goals, again, or economic development colleagues. And so there's a natural partnership here that we need to leverage because, again, to a large extent, the money to do this is in the economic development sector. And so the public health skill competency that we need, next slide, are basically public health, economic, and community development experts. Because we need folks who can leverage our economic and community development activities and colleagues, because those activities have a huge potential to improve health, as I say, particularly in our poorest communities. And in addition, we need to become more savvy within public health, recognizing that our dollars are limited, and so if there are activities that we're engaging in that can actually be farmed out to the private sector because they have an economically sustainable business model, well, we need to be thinking about and doing that. So working with corner grocery stores to increase the likelihood that they will stock and sell fresh produce, that's a commercially viable economic venture because stores that do that will see a return in customers frequenting their stores versus other stores. And so there, again, our business model, this is now about shipping out, not about shipping out core public health functions, but shipping out what actually has, again, a viable business model in the community. So that's the last of this section, but I do have one more key need that we have when thinking our public health workforce, and that's on the last slide of this section. And basically, in addition to all of those competencies that I was talking about, we actually need the very best people in public health, that we are in a competitive economic marketplace. There are lots of reasons why public health may not be attractive to the young, best, and brightest, but people, in fact, in public health are by far and away our greatest asset. And so we need to be thinking about strategies to attract those individuals that are going to do the best job into public health. I think that the increasing awareness and attention that many of our college students, for example, now are showing in global health and global health issues, the draw there is because of the sense of this being something where they can make a difference. And so leveraging this newfound interest in our young, best, and brightest to go into health and making sure that they consider public health in this country as a place they want to go is critical. And so finally, just to summarize before we get to questions, next slide. Times have changed in public health, and we need to also. And in order to move forward, we need a public health workforce with different competencies, and particularly one that's better able to do the things we've historically done better and right, including public health business experts to do more with less, program-centered epidemiologists to measure program products and not just health outcomes, practice-oriented researchers to conduct studies that actually improve our day-to-day practice, and clear, persuasive communicators. Next slide. And we also need to do the right thing. We need policy experts in grass tops advocacy and influence. We need to be developing our anthropology skills to identify appropriate place-based strategies. We need to sort of get back into our workforce those healthcare experts that we need to integrate from the public health side, public health and healthcare delivery. And we need economic and community developed experts, again in public health, to create health community and link with our economic development colleagues. Last but not least, of course, we need the very best people. And the logo on the bottom right from King County is sort of a community partnership model that we have broadly for public health with the slogan of "Let's do this." And I think that probably applies to workforce development as well. So with that, apologies for the little bit of the glitch with the slide, but I will stop and see if there's any questions or comments or feedback on this.
If you have any questions, please submit them now. We haven't had any come in yet.
It is a lot of information in a short period of time. I'm hoping that this may be provocative. It's sort of designed to be that way in talking with folks at CDC. I will, while we're waiting to see if any questions come in, say that the Workforce Development Summit at CDC went really well. I think that there was a huge number of very talented speakers there. And I do think, though, in that context, the notion that thinking not only about how to increase the pipeline that we currently have to develop our public health workers, but thinking about the new skills was a message that I and others articulated and was heard. So there may be progress on this as we move forward.
We do have a question that just came in. The first question is, many terrific concepts here. How would you implement some of them? Please pick an example or two.
So I do think that some of this is going to be dependent on working with, our schools of public health and the people who are developing our workforce for us. And so that will take a longer amount of time. But I do think for those of us in public health practice in health departments, some of these things are things that we can take on right away. And so, for example, the idea of learning a little bit more about business improvement practices and lean. This is a concept that's hot in Washington now. There are a fair number of modestly priced people out there who can do some of the initial work to bring us up to speed on this, and we've gotten them now to come and talk with us, and there are people to help groups of workers work through this. So business practices would be a place where I see we can do this immediately. Similarly, on the grassroots advocacy piece, this is a skill, how to do advocacy for policy, that is very common in the private sector. It's one that we just haven't necessarily incorporated. And so even though budget times are tight, in King County here, we, in a zero-based budget process, identified some things that we would no longer do in order to bring on an individual or two with this set of skills. So starting by an analysis of which, if any, of these ideas sort of make sense to you, but then saying, how can I begin to bring those competencies into my workforce without having to wait for schools of public health to produce folks, is the way to go.
The next question is, can you give some examples of how public health and primary care will work more closely in the future?
Well, that's a great question. I think that's my crystal ball is a little bit murky as to what will happen, but as far as what optimally should happen would be, first off, I do think that with far more people having health insurance, the traditional assurance function that public health has had to assess on a community basis the quality and access of care now becomes something we actually should be doing. In the past, I think we all sort of threw our hands up and said, when so many people are uninsured, looking at a community basis for the reason that appropriate care is not being given, we kind of know the answer. There's a new world now, including a new world with electronic healthcare records, and so working with our primary care colleagues to look at quality and access to care across the community. Individual providers or even individual hospital systems only have responsibility for people who come in through their doors, not through the doors of other folks who are not coming in at all. And the public health stepping up and working in a community to perform that community assessment function is one. Very quickly, I think that there's a role for public health to play in working with primary care to increase the delivery of clinical preventive services now that they're going to be covered under ACA. A huge place that I see there's opportunity is as we think about the Medicaid expansion population and the fact that these are poor folks who in general are single adults and are intensive users of our human service systems like housing and employment. There's a real role that public health can play to work with primary care providers to establish those systems that actually provide the range of services that the newly Medicaid eligible will need to be healthy, the services that go beyond what a primary care practitioner can take care of in an office visit, to include linkage to these other services. I would conclude by saying that I also think that there's a role of working and perhaps cajoling primary care and the healthcare system to become more invested in community-based and population health by working on innovative new community delivery models that may involve public health or other community workers, as well as working with hospitals on making investments from their community benefit work in community-based strategies, policies to improve health in communities. So there's just a whole world of opportunities here, and the challenge is going to be to have the right competencies in the public health side of things so that the clinical care side of things see us as an asset in moving forward.
Okay, the next question is, can you talk a little bit about the importance of academia in partnering with public health to make sure we are developing the right skill sets for our workforce?
Again, a great question. At the Workforce Summit at CDC, the schools of public health were pretty extensively represented. And I do think there's a dawning awareness there that the schools of public health in this country have been better at producing graduates who are going to go on into academic or public health research careers as opposed to public health practitioners. So connecting between public health practice and the academic centers to really educate them about the competencies that we need is a first step here. We are really lucky here in Washington to have the University of Washington School of Public Health and a new dean there, Howie Frumpkin, who has this as one of its highest priorities. And so I think there is a moment of opportunity now as the U is rethinking its MPH curriculum and thinking about what are the attributes of new faculty to work with them, and also to try to be good partners and think about ways that the practice community can work with graduates who are interested in research to provide ideas and provide groups of people to be studied that really tackle those applied on-the-ground questions that we think are the most important.
Okay, the next question is, when you developed these right things to do, did you consider global trends such as climate change? How does a changing global environment inform your direction and the scope of that direction?
These are really great questions. Climate change is a topic that I think that the primary, we need to be thinking about it, obviously. I think of public health ability in the future to respond to climate change to be in part recognizing the overlap between climate change strategies and built environment economic development strategies, and recognizing there's a partnership out there, and the folks who are interested in environmental sustainability that we need to link to, just as we need to link to the economic development colleagues that we have. And in addition, with climate change, recognizing that one of the elements of climate change is going to be the unpredictable, the worst storms, raising of the ocean level and coastline erosion, and therefore really speaking to the generic need of public health to have a better preparedness and response capability to respond to the unexpected. In addition, though, there's some interesting work out. It's called the Global Burden of Disease that's come out of the University of Washington. You can Google it, and it basically looks at global patterns of disease in 1990, and then the second edition has just come out in 2010. Globally, it shows that the epidemiologic transition from infectious to chronic disease that we've experienced here is now almost universal around the globe, with the exception of sub-Saharan Africa. And so we need to be looking and recognizing our global partners are now more likely than not confronting the same problems we are, and we need to be learning from that. But the other thing I thought that was interesting is that there's been a major shift. If you think about unhealthy life that I talked about early on, you know, maybe the last 50 years, the way to tackle that problem was by preventing premature cause of death from conditions like cancer or heart disease. The big shift that's happened in the last 20 years is that now the majority of poor health that people are confronting around the world and in this country is not from conditions that ultimately result in death, but conditions that are disabling conditions. So low back pain and neck pain, arthritis, depression, mental illness, increasingly are the causes of illness, and therefore we need to be getting those disabling but not life-threatening conditions that are preventable more on the radar screen of public health.
Okay. What work is being done to communicate these concepts with those working in human resources departments?
Yeah, well, hopefully it's in part by all of us talking to our human resource departments with these needs. But I do think, while not relying solely on federal leadership, that CDC and the partnership group that they have established in moving forward what they're calling this roadmap for the 21st century workforce has this as one of their highest priorities. So there will be, I think, federal, national attention to this, but for it to play out at the state level or locally, you know, we all need to take leadership in our own domains as well.
What is your advice for encouraging innovation in the workforce?
That's a great question. You know, first, it's recruiting those people who are the best and brightest, as I talked about. Bringing in new thinking into health departments is one way of creating innovation. The second, and this is hard, but it's probably the most important, is to think about in our work environment how to reward what it is that we want. And basically, what are those strategies for recognizing and rewarding innovation in a world where, you know, many people are feeling a little bit beaten down. And that can be as simple as, you know, in many of these issues, the best reward is credit and acknowledgement. So thinking about within our own institutions, the systems that we have for recognizing and acknowledging work, including, you know, awards that are cheap to create but mean a lot to people. And then also thinking about the opportunities that we're creating for people to be innovative, and thinking about, in particular, you know, the new paradigm in training and in leadership development is less around courses and sort of classroom training, and more around creating opportunities where there, you know, is a need in an institution, but creating opportunities for people to spend time being creative and innovative to solve that need. So I think that there's a leadership issue here that can go quite a ways to making these things happen.
And I believe this is our last question, is how will we make time for these changes?
Well, we could work at the federal level to get them to change to a 26-hour day instead of a 24-hour day. But absent that, like all things, and in all seriousness, I think we just need to say that, this is not me speaking, I need to remember that much of what I do during the day I perceive as being urgent, but it's not necessarily important. And so making the time consciously for these important things that we're trying to make happen by prioritizing them over the urgent but less important.
If you have any additional questions, please submit them now.
Seems like we may be winding down.
I believe we are.
Well, Betsy, this has been a real honor and privilege for me to be able to do this. Again, I appreciate you stepping up in the alerts there to expertly handle the slides.
No problem.
And also really appreciate the great questions that people had. This is a to be continued topic.
Well, thank you for joining us today, and thank you to all the attendees who joined us today as well. As I mentioned at the beginning, the slides and the recording will be available on our website, hopefully by the end of the week. And please keep an eye out for the publicity about our next event, which will be in early March. Thank you.